Yeah. Hi all. Welcome back to our podcast series once again. So this is another episode from FCPI. So this session would be completely towards the CP perspectives. Today, me as a moderator, I'll be doing it. Myself, Dr. Sathyanarayana Reddy. I'm a CEB working at Amrita Hospital, Faridabad. So today we have an eminent person who is so expertise in this particular domain, who works as an auditor, who works as an clinical microbiologist, and also a person who is having good expertise in AMS and infection control practices. So I welcome Dr. Malathi Murugesan, ma'am. Currently, she is working in Meenakshi Hospital at Madurai. So we are happy to have you on board, ma'am. Very good evening. Welcome to the session.
So good evening, everyone, and thank you for having me here. And FCPA is doing a wonderful job. I have been following you guys in LinkedIn and all my clinical pharmacists. I told every day you have to go through like how you see news every day. So you're doing an excellent job and you're promoting the importance of CPs. Looking forward to hear it from you for this podcast too. Thank you for having me here.
Great, ma'am. Well, it's our pleasure to have you here. Okay. So, yeah. So, ma'am, generally today theme, I hope you know, it's all about the pharmacist and what is the role of clinical pharmacist in this JCI, NABH institutes and during the audits as per our Indian context we are talking about. So when we start with this, I'll just start up with the foundation, ma'am. So generally the term CP or like the role of CP or like clinical pharmacist role has been started because of this NABH institutes, if not these JCI accreditations. So I want to know, like it's almost from last 10 years, it has been improving. May I know, as per your experience and as per your, service do you have? So what exactly you saw during this complete 10 years? So what you came to know about this? Can we know from you, ma'am?
Yeah, sure. As you have rightly mentioned, it's a decade of change, a revolution, I can say. So before, I think 10 years, only reputed institution would have had the post called clinical pharmacist. So most of, I think you know better than me, than PharmD, once they finish, they move into the research area, pharmaceutical industry, and the vacancies, or they don't know what to do in hospitals because hospitals will not have such an opportunity, or even honestly, the hospitals don't know what responsibilities should be allotted to clinical pharmacists. So that was the scenario before a decade. Before 5 years, when most of the hospitals move into accreditation, the role of CPs have been a game changer, mainly because of accreditation, I must say, because we know what exactly a CP should do because of NABH and JCI accreditation. And now most of the centers are moving into accreditation. They are hiring CPs. Previously, when we use the word CP, they may not even know what is CP. They'll ask what is CP. So now they know what is CP. So that is a best thing that is happening in India now. And as you have a federation now, people are coming forward. The CPs have the confidence to go and ask in the hospitals that they have an opportunity. So that's been the change for over a decade, that people know what is a clinical pharmacist role in hospitals, and they have a job opening in hospital sector also, not in tier 3. As you have given my introduction, I'm from tier 2 city in Tamil Nadu. So we are actually catering village population. So we have also 6 clinical pharmacists in my hospital, which is a 250 bedded. So that's how you are evolving. So let's see.
Great to hear your journey, ma'am. Yeah, it's true. So it's like as per your understanding, ma'am, like in India, as per institute to institute, I mean hospital to hospital, the roles of CP or job description of a CP would be different from different settings. So what do you feel? I mean, as per my knowledge, I know you are also doing as an auditor and giving many, speak sessions, and you came to know all about this. So what you feel like? What exactly CP roles, as per the Indian context, should be when we are taking a baby steps now?
Yeah, so ideally, I think if you have had an experience of talking to a CP in abroad, they actually do the job of a medical practitioner. So that much role they have in abroad. So
Yeah.
in India, we have a lot of challenges. I think every CP who have gone to the ward rounds will know the challenges that they are facing through. So as
Yes.
you have rightly mentioned, baby step. The best advice I say my CPs don't directly hit into medication advices to doctors. So that's like exactly you're throwing you like a battle. So the best advice is like the clinician should feel that you are actually assisting them or helping them in finding out the errors and assisting or helping them in patient care. So that's the aim of everyone. We want to talk about patient care, patient safety. So that's a baby step is to aid in the medication safety. So most of the time, the CPs are first utilized for medication errors capturing, and then medication recall, and then mainly in oncology setup for chemotherapy. All the chemo pharmacists are being utilized effectively across all the sectors. Next is AMSP. So that's a very different tough job. So these are all the key responsibilities first a clinical pharmacist should start up with, so that the clinicians doesn't feel that they are being replaced by CPs.
Okay. Yes, that is true, ma'am. Like, this is a kind of challenge we too have during our rounds when we are doing for, when we are going for this clinical rounds and when we are interpreting a cases. It's always like we need to approach something like we are adding a benefit to them, but not like something we are, showing a finger against them.
Yeah.
Yeah, true. And ma'am, like if you see this, like what and all ways we have a CP can enter into our institute and where and all areas he can explore. So as per your, I mean, in your hospital or like as per your knowledge, what exactly this medication safety mean? And also how this your experiences added, I mean, for example, many clinical teams a CP need to deal with. So when they are dealing with many clinical teams, what exactly we need to do, take into things like how to convey it, and followed by what is a way of convincing them, and how we can improve our compliance rates. So can you give any suggestions regarding this, ma'am?
Yeah, true. So most of the time, what happens is when the clinical pharmacists finish their PharmD and directly go into as an intern or as a fresher. So the communication is a major challenge. They know that they have pointed out some errors, but the way they communicate it to the nurses or the doctors should be very, very, very diplomatic. That's the way I always say. Don't just because once you find some error, you feel like you are the hero. You got something wrong, and you want to show that you have found out something like eureka moment. So you rush immediately and say that I'm here to find out the errors. That's not the way to convey, because once you plot the error, you will be looked like an enemy among the nurses pool. Whenever you enter, everyone will gaze at you like an enemy. So we have to first politely convey it to the nurses and ask them why this error has happened. So instead of saying that why did you do this error, all those things, first go a background check of root cause analysis of why this error has occurred. Maybe due to knowledge issues, they wouldn't have even known the dose, especially like newly joined doctors who may not be specialized in maybe a medical officer who joined in a cardiology unit may not know the exact dosing of the particular drug. So verbal orders would have been mistaken. So awareness should be there, education should be there. A simple placard of the most common drugs with the doses can be prepared by a clinical pharmacist. So when you go and say, just don't say errors, you can say that this is the error. We have a solution. We wanted to make a commonly used placard with the dosings that is available in a pharmacy with the generic name and the brand name. You can project it in the particular ward if it's a small setup, or put it as a digital display, send it to your common doctors. So if you go in a way with solution, people will always accept because you're helping them. So they will always accept. So this is one example. Likewise, every error, you should go with a solution. So that's advice.
Yeah, true, ma'am. Very well said. Very well said. Thank you so much for this valid input. And also, ma'am, when we are, going with the CP's profile and CP's, duties and also the day-to-day challenges. So mainly it comes during clinical audits and also internal meetings and also monthly meetings, presenting the data. So during this time, a CP, I mean, a person from the clinical pharmacy department or like who is representing this, how they can, go with this even presentations, ma'am. Like the way you gave a suggestion regarding approaching, even reaching to the wider audience, like administrators, head of the departments, and head of the institutes is very important so that the change or the thing like background, what it is happening will be, conveyed to them. So this is very important in audits, maintaining data. So how this also can be, started when it is like something like we are taking a baby steps now.
Yeah, so that's true. So as I have told, like mainly the recruiting part of a CP is because of accreditation. So the data speaks. So from management, let's talk about management point of view, HR point of view. They want the data from you. So if you have genuinely collected the data proper, if you're presenting it in a forum with full confidence. So where will the confidence come from? If you're true in your data collection. So if we have just
Yeah.
collected only 10 samples and presenting that out of 10, 9 is error, we can't say that, no. So the sampling should be appropriate. You should know the basic statistics. Every clinical pharmacist working in an accredited center should know the auditing requirements, auditing etiquette, and how to do the statistical analysis. If you have a very good information systems like HIS, then it's easy to take out. So just learn about basic statistics. And when you present it, always present it with your denominators, how you took the data, not just saying that this month, this much medication errors, this department, this much medication errors. That's not going to help them in any way. More important is a trend. Just if you have joined this month, going and presenting just errors may help, but what is the trend analysis? That's more important for them. After the CP comes in, so let's say before 3 months, the errors were high, and after the CP comes in, the errors are coming down. So you have to show the data effectively in a way that it is helping the management also, both for accreditation and patient safety wise, that errors are coming down. So learn some statistics, be good and confident in presenting what you are. How you can be confident? It's mainly if you do have done the groundwork. Some of the CPs I have seen, they sit in the computer all the time. They just take data from the computers. That's not going to help. You have to go to the website. You have to see what's happening. If you have found an error, you have to go to that particular place and check why this error has happened. Pharmacy related errors, go to the pharmacy. Maybe a new person would have joined. He doesn't know anything about it. So night shift duties errors happens. So if when you're presenting, if you can present that I have visited this place, then obviously everyone will listen to you.
Okay. So it's all about speaking with the experiences and also exposure.
And yeah, that's we say that Gempa walk. So you have to go and walk and see what's happening, not just sitting in a system and seeing the numbers. Sometimes the numbers or the system data would have been also wrong. The person feeding it could have been wrong. So if you have visited the places and if people knows you, that's more important. Sometimes when we present in the forum, they'll say, who is this person? Then we will introduce that this is the clinical pharmacist that we have recruited.
True.
They've been with us for 1 year. Then they'll say, oh, there is a clinical pharmacist. That's a question they will ask us. So
True. Yes, ma'am. And also, these days, two things are very booming towards this medication error, medication management, safety, all these things. One is AMS because of this increase in AMR, and another one is oncotherapy because of immunocompromised patients. So I want to, like, we as an audience want to hear from you, ma'am. Like, when a CP is recruited in this AMS departments or ID departments, and also when a CP is recruited in onco departments, so what it is different from the other normal CP duties, and what and all things are important? Could you please let us know as per the NABH and JCI standards, and why it is different from each other?
So other common pharmacists, their work is mainly to go for rounds and look for the case sheets and see whether some error has happened and how they do the drug dilution and crash cart audit and narcotic audits. Is the basic audit that has been done by the routine clinical pharmacist.
Yeah.
The ID clinical pharmacist, we say IDCP or AMSP pharmacist, and chemo pharmacists have a dedicated role. So they should be privileged, they should be trained specifically to look certain items. And I would always say they should be having the knowledge equal to a physician, because they have to have a communication. For chemo, again, they have to have communication with the patients also. So they should have very good communication skill. They should be equipped with very good knowledge. Then only they will be able to do this work. So what is difference in ID clinical pharmacist? because it's not just looking at the charts. They should have basic microbiological knowledge also, which bug will work for which drug will work for which bug, what dilution they have to choose, and whether they have to give a normal infusion or extended infusion. They should be updated with the recent IDSA guidelines, and they should be involved in the antibiogram and antibiotic policy preparation. So their work is very, very different. So they become a part of the AMSP committee. I can even say they are the core pillar of the AMSP committee. So they should know everything in detail. They should get trained in the microbiology laboratory also, so that they knows why this particular drug is not being reported. So that we call selective reporting. They should know all these things. Otherwise, what will happen? The clinician will say, I'm giving meropenem. They didn't report meropenem. They'll ask this to the CP. If the CP knows that it's sensitive to piptas, that's why the microbiologist didn't report meropenem. It's easy to answer, because if you have been experienced in microbiology reporting also. So it's an entire ball game, different from what the routine CPE does. So a training should be different. Maybe I would suggest 3 months of training in microbiology and ID will be able to go to the groundwork for ID. When it comes to onco, I'm not an oncologist, but we have a dedicated onco clinical pharmacist. So she, her role is every day, the chemo drug, she's not calculating the drug dilution, but once the doctor writes the prescription, she's the one mixing the drug, and there is one more onco nurse also. So they both do in the biosafety cabinet, and then it's been given to the patients. Also, she counsels the patients who is going for the discharge with the chemo drugs. And she regularly takes sessions on chemo drug safety, precautions, everything. So that's been done by her. So this is like, again, different. We all know that chemo drug has a lot of complications, the way the safety for the person, the more important is the healthcare provider safety is more important. How to prepare it, and how effectively you have to use a biosafety cabinet, where to discard all this waste, everything need to be known by the clinical pharmacist. So that's the different area, and most wanted area for clinical pharmacist also, these two areas.
Okay. So how does this NABH and JCI, accreditations look for indicators, compliance rates, what and all? Like, are there any differences, ma'am? Significant differences?
Yeah. So for AMSP, I'm going to talk more about AMSP, because for onco, I don't have much experience. So for AMSP, I think we all know that 6th edition clearly mentions about all the AMSP indicators also. So once we finish the antibiotic policy formulation, we have to check whether the people are compliant and using the drugs. So there are certain key performance indicators. One is the DOT, LOT calculation, and then another one is the defined daily dose, DDD calculation. And some hospitals have efficient use of pre-authorization of the drugs like Kefta, AV, colistin, minocycline, or the higher end drugs. So for this, if there is only one ID consultant, it will be very difficult to ring the ID consultant at night time and get the pre-authorization. So the clinical pharmacist can be effectively utilized for the pre-authorization. If you have 2 to 3 CPs, they can do the alternate duties carrying a pager, and they can approve it. So the main KPI that we follow is DOT, LOT. For that, every day the CP should go with the prospective audit form, or if you have a digital system, capture the antibiotic data. Every day, put day 1, day 2, day 3 calculation, and calculate the DOT, LOT, and make a trend analysis. All the DOT, LOT, and DDD is not going to help for 1 month alone. It is basically to look at for the trend analysis. So this is very important, especially for full level accreditation of NABH. And JCI, it is very stringent. So this is most needed. But I don't have experience in JCI accreditation, but this is what we also do here.
Okay. Okay. So, as per, I mean, when you go as an auditor to any kind of institute, so when a person talks about AMSP and IPC, so what and all like key indicators, KPIs will be looking into as a first look, like first impression is the best impression, generally people will say. So, what is the first list of things you will be having in your mind as an auditor, ma'am?
So for IPC, we have always 7 indicators. One is the CLABSI rates, COTI rates, surgical site infections rates, and then WAP rates, hand hygiene rates, the segregation rates, and the surgical prophylaxis rates. So mostly the SP audit will be done by the clinical pharmacist. For AMSP, we ask these data like DOT, LOT, DDT. And some hospitals, the beginners, they will not have much data of DOT, LOT. They'll just have one form called restricted antibiotic form, which we don't know whether it is being efficiently utilized or not. So there are some 6 and 7 antibiotics, they'll put it as restricted antibiotic. Mostly the clinician would have started it after 2 to 3 days to find out this clinician and ask why this antibiotic is started, to get it justified is not a very good key performance indicator. Maybe it is just for namesake being done for accreditation purpose. But when we look at for real-time effective utilization of the AMSP services, these justification forms are not going to much help in implementing any policies. So these are all the KPIs that we see from HIC and AMSP.
Okay. Generally, we also feel few.
Anything I missed it, maybe if you can name it, maybe.
Yeah.
I think
See,
it's the most
it's
common. Yeah.
yeah. We too generally find these daily challenges, man. For example, we'll be documenting all these justification forms, like where and all this restrictive antibiotics comes into picture. We will be maintaining all this, justification forms. But few will be listening, and we will be having resistance from few departments. So if something it is happening like this, for example, we have good compliance for 5 departments, and we have non-compliance, and they are not showing much resistance towards this with few departments. So when we have this kind of thing, how to present a data so that it can be taken to the administrator level, and considering this audit things, because for administrators, for every person, it is like audit is a prime most thing for the hospital. So they'll take this as an important. So how to present it in such a way that it can be convinced? Could you please add with your experience, ma'am?
Yeah, I would always say like what happens is like you do a monthly audit and then present it in your HIC committee or AMSP committee where only few people will be there. Only
Yeah,
those will know what's happening. And the ground reality of CP is working hard and ICN's working hard to get this data. It's not easy. No one knows how hard is going and getting all these numbers. But most of the
yeah,
time it is just used for accreditation presentation, not for not blaming all the institutions, but most of the times that's the reality. I think most of us will agree to it. So the best suggestion is not presenting in the HIC committees. When you finish an audit for a particular department, let's say transplant, you have finished your audit, go and present it to the transplant doctors. So every department has a department meeting. Like when I was in CMC Vellore, every week they have departmental meetings. So like currently now in my institution, every Tuesday morning, 8 o'clock, they have gastro meetings. You can just ask 10 minutes time. So 8:50 to 9 o'clock, you go and present your hand hygiene rates, present their antibiotic usage. If you present it to them, they will know what's happening in their department. They themselves will give solutions. Oh, maybe we missed it. We will do like this. Then you go and present it in the administration. So if you directly go and tell that this department is overusing all these things to administration, then when administration talks to the particular end user, you will be looked as an enemy. So always go from bottom to top, not from top to bottom.
okay, okay. So generally when this audit happens, like NABH or JCI, so we have few documents we'll be maintaining as per our checklist. But when you take this the recent one is 6th edition of NABH. So as per the auditor mindset, what would be they'll be preparing, ma'am, like the key most areas first an auditor would be looking into, where and all the CP involvement, where and all this ICN involvement, where and all this microbiology, the major departments like biomedical management. So all this comes into picture. So where and all you people would be like mostly as an auditor, you'll be looking into, and where we need to improve, ma'am. Like, could you add this input too? So it would be very useful for our audience.
Yeah. So from auditor point of view, the first question is whether the data is true. That will always be a question. So they'll be presenting some 10 errors, 20 errors, and we know that this is an underestimated data. Being an auditor, been to multiple hospitals, we know what is a baseline error rate in India, in tertiary center or in small centers. So always don't try to hook up the data, because that is a bad impression. People always feel that showing 90% compliance is good. Okay, the assessor will feel very happy. No. If you present even 40% compliance, But if you have taken action that this 40%, we have done some action and improved to 60%, and we are aiming to improve to 80 to 90% next year, I have a target goal set. This is what accreditation wants. This is what quality journey wants. Not showing 100% compliance, good marks all the time. We don't want good marks. We want you to find the faults and give solutions to improve the faulty mistakes. So that's so when you do the initial presentation itself, the auditor's eyes will know whether it is a true data or not. So if it is not a true data, then the whole 3 days drama is done. You will be caught.
Yeah.
So always present your genuine data. Even sometimes your administrator will say, why are you presenting this much errors? We will be looked as we are a reputed hospital. We will be looked like bad in the eyes of assessors. Assessors have signed a confidentiality agreement, so they will not be disclosing your hospital name anywhere. So that's the first advice. Second is always just don't present data. You should always have a root cause analysis and karpa. That's most important. What did you do with this data? Not just having numbers and graphs. Was this conveyed to the stakeholders? That's what I've been telling. Whether the department knows it, that you're doing it, whether they know you are a CP and you're doing all these things, and what corrective actions you have taken. These documents will be asked mainly by the assessors and auditors, especially with 6th edition. They are very stringent in looking at the RC and CAPAs for everything, for all the audits.
Understand. Okay. So generally when it is documentation, for example, the audit has been done today and the kind of report has been given by the NABH body. So like what is the duration or what is the tenure that we need to maintain a document, ma'am?
Okay, so that's mostly, it's a hospital policy. Retention policy is hospital policy. Most of the hospitals keep it for 3 years.
Okay.
Because the renewal
Okay.
and other things will come in 2 years time, no, the NABH auditing. So they keep it for 3 years. If you have a digital way, then like what we do is we scan it and upload it, and then not the raw data sheets, the final numbers anyways, we are going to present it as a soft copy. So we will have a digital backup in a hard disk, and 3 years we'll be having the raw data sheets.
Okay.
There is no
Okay.
guidelines as such from NABH to say that MRD data, patient data, we have a retention. But for the audit sheets, we don't have something like that. But most of the hospitals follow 3 years policy.
Oh, okay. 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 Then it is like something, it's like completely in hospital norms it would be
Yeah,
working on.
mostly all the hospitals keep it for 3 years.
Okay. Okay.
With
Thank you for
fire
this point, ma'am.
safety and other issues, no, you keep so many things in your storage room. Then the fire team will come and ask auditing you also why you are keeping this many papers.
Okay. Okay. And also, ma'am, during this, this audits or like the CP presenting data, it is always dealing with an interdisciplinary teams. Is most of the thing happen? I don't know. Like in my few of experiences, most of the people who are, as per we segregated for department, one person need to be there minimum to understand what is the picture of each and every department. So as you mentioned, going to their department and presenting it and making something benefit out of it, like asking for their time and getting an output. Yeah, it's a really valid point. But if there are hindrances, like for example, we can't even something convey, and the department is like something we could not even. We are zero on day one, and we are zero on day 100. So in this kind of situations, like during an audit, because I have this experience in my last experience in my last institute, because I could not answer this. So how to deal with this kind of thing during audits, ma'am?
Okay. So 100 days of war. Okay, still zero. Okay, so then it must be, so 2 ways. We have to look at both ways. So one, from the clinician point of view, they may feel like they are 100% good in what they are doing. They don't want somebody to come and poke inside their department. If you look at the other way also, other edge also, the CP should be very, very knowledge to talk to a clinician level. Let's say, no, most of the times, I think you all will agree when you join as a fresher, some questions will be asked to you to find out whether you know this thing or not. The doctors
Yeah.
and other people will ask some questions like to check whether knowledge level. So for 1 week, you
Yeah.
will be asked only questions. You will be given homework. You will be looking at all the app-based platforms to learn. So I would always say, if you are going to talk to a HOD level or senior consultant level person, you should have at least have 1 year of training. So that's it. So the problem is most of the hospital there'll be only one clinical pharmacist who is just recruited. So he has to go and talk to the HOD. So in a forum where the HOD and the juniors are there, if the HOD is making sarcastically saying something against the CP, the value of CP among everyone goes down, and inner feel of a CP also goes down. The motivation goes down. Okay. So this may happen, and maybe would have happened also across all your peers and colleagues. So that's the suggestion is, any newly joined CP, I would always recommend to put them under the what to say, and shadowing of a senior CP.
Okay.
So better is like, if any fresher is coming to me, I would suggest that go and learn for 6 months, and they'll be put up as a shadow. They will go along only with the senior CP. So senior CP only should talk. If the junior finds out something also, I know the junior wants to say that I have found out this, but convey it to the senior. Senior talks to the HOD. Otherwise, what will happen, no, it's not only for CPs, it happens for every field.
Okay.
So once you are equipped, go and talk to the people, then obviously they'll accept. If you're saying something, nobody will say no.
Okay. Okay.
So maybe 100 days, would
Yes.
have been like one-on-one fight, or I don't know, because we don't want to talk about it now. But
True.
maybe if you're a trainee or fresher, you also will have some fear whether I'm conveying the right information on that. We will have not only CPs, every fresher, even MBBS or nurse will have that fear, even if you're 100% correct in saying, but the fear will give the communication will not be with confidence.
Great. Yeah, true now. So to just extend this to next level, I want to ask, like, in your experiences, like what and all strategies you followed, or what and all strategies you implemented, even the CP department people, to collaborate with the multiple teams and make it possible to get a best clinical outcomes and also compliance rates, as per your auditing experience, like that you observed the best one. Could you share with us, ma'am?
Yeah, sure. Right now, my CP is calling me. Her name is Reema. So we have 5 CPs now. Ours is like a newly open hospital 1 year. So what we have done here is we have dedicated CPs for each specialties. We have super specialties. So neurosciences, there is a separate one. Cardiac sciences, separate one. Gastro sciences, separate one. So like that, we have dedicated special CPs, and every 6 months we rotate them because they also want to learn all the specialties. So that's what
Yeah.
we. So during that rotation, the last 3 days, this person will be half a day going to the department and half a day they will come to this department. So the handing over is smooth. And they have to introduce the CP to the particular HOD also, that this is the CP going to be with you for 6 months. So they go for rounds along with the surgeons or the clinicians. So in the morning 9 o'clock rounds, they go along with the doctors. So then and there, the doubts will be asked to them. Then and there, like you finish one rounds and move to the other patient, then the CP will go through the case sheet. Any errors, they will immediately pinpoint and finish. The ones in 1 hour rounds, they will be able to finish all the errors also. So, and because once the HOD says we have PGs will be writing the orders immediately. So the CP will be able to look at whether they are writing it correctly or not. From AMSP point of view, or antibiotic consults, again, during the rounds itself, the HOD will say the CP, we have 2-3 growths. We wanted to have a consult with the microbiologist. So that also, once the rounds is over, they'll be communicating. If this integration happens in one go, it's easy. Let's say the rounds finish in 9 to 10 and the CP comes at 10 o'clock. The surgeon will go into the OT and come back only by evening. By the time the CP will finish the rounds and go, and nobody knows the CP has come or not. So very, very important is clinical rounds should have the CP together, and it's very well accepted in my institution. So that's the one simple mantra. You have to be there when the doctor is there.
Okay. Okay. Noted, ma'am. It is true. Even we in the early days, I too don't know this point. I used to be just, like be at a shadowing point. I used to like even not even enter into the ward because of this kind of inferior or kind of fear to talk with the doctors, because it's a kind of a beginner or a budding pharmacist or budding, every person who enters into the field will be having this thing. And I too learned all these things from my seniors. It's kudos to them, like I need to be very gratitude to them for all these things they have learned, made me to learn. And also, ma'am, when we talk about this communication, or when we talk about this conveying things to in between teams, communication plays an important role. So even in audits, the way we present it, the way we talk, and the way we convey the complete data, or what and all our observations, what initiatives we took, what and all reasons we found, and how we came up with the kappa, all these things would be happening. So if you talk about the communication during the presentations or during the audit days, how should a person, I mean a CP who is representing a CP department, need to talk, take it forward, like the way, because always the auditors should be way experienced than us. Communication is also a very important thing, that always there's a myth like our communication will clear off almost 60-70% of problems. So what is the role of communication in this, even presenting, talking, and all?
So let's talk from direct communication to the consultants or nurses, let's say. Okay, so when you go for something and you find that a doctor has written a wrong dose or wrong route, or maybe instead of Q12H they have written Q24H, or renal dose adjustment was not done for this drug, you can't directly correct it. Some hospitals, they have the CPs that can directly correct it, and that can be taken as an order. Some hospitals, they cannot do it because the prescription has to be written by the consultant. Okay, so most of the times you cannot reach the doctor. They will not be there 24/7. So CP may say, like initial days, my CP will say, I couldn't find the doctor at all. This is the error I found, ma'am. So they'll give the paper and they'll go off. Then I'll be calling and conveying it that antibiotic dosing is wrong. So then what we did is, like, we got one single point of contact from each department, as we are a teaching institute. We have a D&H teaching institute, because the seniors are difficult to find. So get one single point of contact for each department and get the phone numbers of them, introduce a CP to the particular person. So choose somebody who is not so strict and easy to approach, and who loves doing these audits. So that's more important. That person should be passionate in listening, because they're very busy. They won't be listening all these things.
Yes.
So choose somebody like that. So that's the role of auditors or quality department or management should do that, and communicate
Okay.
it to them. So their work is to communicate it to their HOD that the CP has told me that this error. So that's, so it's easy. You don't need to find out who is doing all those things. You have that. So that's the easy way of doing the intra-departmental communication. Talking to an auditor, now when presenting it to an assessor or in the HAC committee or the pharmacotherapeutic committee, you need experience. So you need to have a very good leadership. You need to have a very good clinical pharmacology or pharmacy head. Learn from them. And maybe if you have a very good quality head, you can learn from them. It's not like I can teach now in 5 minutes how to communicate or how to do a presentation. But nobody like when I was doing my first presentation to NABH, I was very, 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 very tensed. That was my CMC NABH presentation. And the first time I joined in a month, and within 2 months, we got full level NABH, and I was a HAC officer. I don't even know what is NABH at that time. But we had a very good mentor support. I had almost 5 to 6 times of mock rounds of presentation, and internally people threw me questions of how the assessor will ask me. So like that you can do. So if you are a fresher, you're going to present it in a forum, do a mock presentation. Do like what I did is, like nowadays even I do. I open a Zoom, I do a self-recording of my presentation, and I listen. The eye gazing is very important. So even now I'm not good at it. So I wanted to look at only the mirror, the webcam mirror, but I'm gazing my eyes here and there. So you can do a mirror presentation, or you can do a self-Zoom presentation, and you have to find out what you're not good at it. So eye contact is very important. Your vocabulary and English should be at least a way good, because I know we have multilingual policy in India, but English is a basic one we all have to have in confidence. And if you're presenting a true data, then obviously, so Satyam is very important. So So that's your name also.
Okay. Thank you. Thank you. And yeah, I mean, you are saying that we always need to find a person who is good at communication and also who is, and also before going to audit, we need to undertake
Yeah,
internal audits.
very important
Yeah.
is mock. You should do a mock and ask your seniors to be there and ask them to throw questions. So what will be the question
Okay.
from the committee or from the assessor or auditor? Because these persons would have an experience of going through the audits. They know what will be expected in each slide. Each slide you have to go through and they have to throw you questions. You have to answer.
Yes, yes, yes. Yeah, this is one of the strategy I came to know. Thank you, ma'am. But when we are going to this mock interviews, is it like we also, I mean, I don't know whether it is recognized or not, but even GDS, housekeeping staff, uh, the person like non-medical departments are also important because auditors also will screw us towards this biomedical management and also towards this hand hygiene when we are dealing with the housekeeping staff and nearby bedside, the cleaning things, all these things. So when we are dealing with these kind of people, we need to have one of the person who can talk very good with the auditors. So how to deal with the non-medical teams, man?
So there is a problem as a language. Most of the time, the auditors talk in English. Like, let's say I'm from Tamil Nadu. None of my housekeeping staff knows English. So even at
Yeah.
the supervisor level, they're not that much fluent in English. Most of the time, the assessor will not ask them to answer directly in English. Nobody pushes like that because as an assessor etiquette also, all the auditor has been told if they are not good in the language, then somebody should be translating them. So as you will be seeing in the accreditation, the auditor will choose one person. Like most of the time, it will be me. And I'll be standing there. So the auditor will be throwing question at me. I'll be translating it to Tamil and the person will reply in Tamil. Then I will again translating it to English. The tricky part is sometimes whatever they say in Tamil, you will be translating something in English, which is 100% correct also. So that also happens. But assessors are very good in looking at the face and finding out. So nowadays, all the assessors, like recently in our NABH, there was no questions at all. There was full of mock. She just asked to call the housekeeping staff and asked her to do the mopping. Show me the mopping. She asked to do the spill management. She said, no need to explain me, no need to talk, just do it. Even medication, she asked one of the staff, she told, go and do this medication mixing, no talks, no explanation. Because immediately once they said, the staff said, I will open, I will do hand hygiene, I will do 6 steps, I will wear this. She said, no talking, do it. So nowadays, all the assessors are doing only skill-based evaluation of what is happening.
Okay. Yeah. I do experience the same, ma'am. If you remember, you asked us to do the spill management.
Yeah.
Yes. So coming to even this training part, educational, CME is continuous. So like in audits, how worth are this, ma'am? Like what and all, like what priority this continuous medicational and continuous medical educational programs that has been given as a part of this auditing, ma'am? Like how value and how importantly you'll be looking into that.
So training is very, very integral part. There is a separate standards on HRM, which talks about training, skill, and then proficiency testing, competency testing, and also the privileging part. So somebody who has joined new as a CP, they have only few privileges. They cannot directly give consults. So after the training and maybe after a year, they'll be more put up into privileges. So this privileging is basically based on the training they have attended, how equipped or competent they have become based on the skill training and also the routine lectures and others training. So this is vital. I will say this is the heart of everything in the world, not only medical curriculum. So I think most of the hospitals will have induction program where there is no much talk about medication safety, because we talk about
Yes.
BLS, we talk about infection control and things. But
Yes.
in routine training programs, we talk more about the medication safety, hemo safety, other things. It's very, 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 very important. All the freshers should go through it. So for in our hospital, the CP are taking regular sessions on medication, MOM chapters, what are the important medication related,
Yes.
multi-dose vial policy, how to label the syringe, how to label everything, they do it. So it's very important. CP play an important role. And antibiotics also, the There are whiteboards in each places, no census boards. Half of the census board is for education. So just one antibiotic every day. Meropenem, how to dilute, what is like that they calculate and they teach in the leisure time, they do it. So on-job trainings is also important. CP should do it. So that's how CP also will learn. So once you want to teach, you learn, you can also educate yourself.
Okay.
From you asked about accreditation point of view. So when assessor comes, surely they will look into the training records. So what is the induction training topics or who and all attended? Mostly we wanted to ask how many doctors have attended, because most of the time nurses, all people would have attended, doctors wouldn't have been attended at all. So that will be asked. Nowadays, specifically for AMSP training, antibiotics related training, how many doctors have attended the training is being targeted by the assessors.
True, true. Yes, ma'am. That is really true. And so if we count this, we have a challenges. I mean, as a clinical pharmacist, I too can, see the challenges and also opportunities we have. So during this audits, so what are all the common challenges a CP will be facing as a context of NABH, and how that is different with JCI? Are there any differences that need to be, like a person who is preparing for that need to consider, ma'am?
So JCA is more stringent, it is more continual. So they'll be looking at, like when they come like after 2 years or something, they'll be looking at what you have done since the previous JCA. I have not
Okay.
worked in JCA accredited centers, but you are, I think, working now. You are working in a JCA center? No.
No, no, no. We don't have a JCI.
Okay. So what I could hear from the people who worked in JCA is it should be a very country. Like NABH, mostly they'll ask only that 6 months data or the 3 months data. If it is a fresh open at beginner centers, 3 months data. So it's easy to just make the 3 months data, because then the reassessment comes. What will happen? That scenario is 1 year. People will be like having a cool period. And then when the reassessment is being applied, quality will say we have applied for the reassessment, then everyone will start panicking like, oh, I don't have the data, I have to capture the data. So that's a problem with not
Okay.
following what we want to do. So why we want to go for NABH? We actually, as an infection control professional, I actually want to utilize this accreditation as a way to push people to do it. So it's not
Yes.
accreditation is going to be a changer. I'm just using the name so that I can implement things. So if I am not doing at the times where accreditation is not happening, so 1 year I'm just simply sitting and enjoying, then people will say, okay, only during NABH this team will work, and the rest of the time this team will be in the silent mode.
True.
So don't just do only for NABH or JCI. Always follow what they recommended and do it at all the times. So I would say there is no change comparing between NABH JCA. You are going to read what they say, and you're going to, every day is your accreditation day, every day is your NABH day, every day is your JCA day. So that's how you have to work. Then only people will acknowledge you.
Yeah, it's very true, ma'am. It's very, vibrating the way you are saying. Every day is an auditing day, and every day we need to prepare in such a way. If this comes into a mind of a person who is just really, it's all about the ease. So it will be going very smooth. Yes, ma'am. Even this is the one thing which I should not take the name. I don't know whether I can take or not, but my person who is sitting in the Samrita hospital will be saying every day, it's with the ease how we will be doing the work, then only we can get the best output.
So
Yeah.
that the accreditation will be there just like every day, no? So if every day
Yes.
you feel like an accreditation day, then the day the assessor comes also, you feel like a normal day.
The
Then
same.
no,
Exactly.
celebrate that day like some birthday moment, like you be like dressed up differently, wear mask that day alone and dressed up like differently. That every day be like the same person.
True. True. And how and healthcare institutions can support a clinical pharmacist to overcome the challenges and to enhance their contributions? As you are a person, I mean, a chairperson of HIC and also AMS in your institute, and also having an experience as an assessor. So, could you please give a input to this as per the administrator and as per the assessor? So, we want to hear towards the both perspectives.
So now I think most of the administration knows the value of the clinical pharmacist, especially as I told after accreditation. The only problem in India, I think I can't say now, but I think you all agree with there's a salary issue. So the pay scale is a bit lower than what is expected by the PharmD. So when they go to
Yes.
a pharma industry or a research or an ICMR project or any project, so if they go into the project model like a scientist, they go into abroad easily through that peer reviewed publications and other things. Again, pharma industry,
Yes.
they get very good pay scale. So the amount of work and hard work and being put up into the healthcare, when I talk to the clinical pharmacists, they feel they are not being given an appropriate pay scale. So that's the
Okay.
message. Like I think a lot of CPs convey to us also that the healthcare should support them with the appropriate pay scale. Next is like not only like accredited centers, like let's say like I'm in tier 2 now, there is a tier 3 also near to me. Like there are few people who have called me and asked we need CPs. If anyone who is left, let us know. So it's not just like we think actually. Not only accredited centers, even the small centers also want CPs. So the healthcare is actually supporting. Uh, in last 2 years, especially post COVID, this has changed a lot. Last 3 years, I think I can see that small hospitals, just 50-bedded hospitals, are having a clinical pharmacist and effectively utilizing them. So that
True that.
healthcare is changing. So it's high time the clinical pharmacist should equip themselves. You can't
Yeah.
be escaping from us. So because we will be asking questions. So you,
Yes.
so I think your colleagues and other, I think you're doing a very good job in FCPI. But like the freshers, and especially I would suggest that FCPI to should target the students also, like
Okay.
internship, they should know their role. Most of the time when the interns come to me as for the interview, when we ask, they'll say, what did you do? They'll say only ADR. They have been utilized only for
Okay.
ADR. So they don't know their responsibilities. So you have to have some internship pool, tell them, so they have to start learning. Even if they go for a hospital internship, even if they're just utilized only for ADR, you can have ample time. You can just go through the case sheets, you can learn. So that thing has to be initiated by the CP forum so that the healthcare will know that this person knows what they have to do first. So during interview, when I ask what is your
Mm.
responsibility, they'll only say ADR. So that's
Yeah. The same thing with me now. I need to accept it.
sorry, not offending anyone, just because you are most needed now. So you should equip yourself more so that people will be grabbing you more than you think.
Yeah. Yes. Exactly. When we fall under the hands of good mentor or something like that, really all this really will change, man. We are also trying to, move out of this and explore the new origins of this. Definitely, I hope it will be very near. We can see that. Yeah. So, like, if by seeing all this, ma'am, like, what you can like expect from the CP in upcoming next 5 years, regarding this accreditations, regarding maintaining the quality in the hospital programs, and also to what extent we can envision ourselves. So, could you also add a note on this?
Yeah, sure. So as of now, let's talk about my personal experience. Like when I was alone in my hospital for the first 1.5 years, like every time whenever there is an opinion, without seeing the whole case sheets, no, from right from the beginning, the investigations, everything, we can't give any opinions, right? So it was very
Yeah.
tough going and seeing all the patients. Let's say even just 5 patients per day. I think if you have done an ID consult or an antibiotic consult, going through the case sheet and asking the history itself will take half an hour, and then talking to the people. So that itself take 1 hour. So and then sometime night consults will come, Sunday consults will come. So it was tough. Having clinical pharmacists now in all the 5 departments, it's very easy. So first and foremost is I should have the confidence that the information that the clinical pharmacist is giving to me is correct.
Yeah.
Only I can tell something over the phone, like Sunday, let's say I'm sitting at home. So the CP should be very knowledgeable and should know what information I will ask. So now, like, they know what I'll ask. Initially I'll ask one by one, what is this value? What is that value? What is the previous culture? Each one she will go back, and there'll be 10 calls for one person. So at that moment, if I got irritated and say, you don't need to say I will come, then she will not learn. So at that time, I should be patient, let her learn, let her come back. So now she knows what is the thing that has to be collected right from the admission. She comes with one full paper of all the data and she presents. Okay. So it all comes from whom you're working under. The mentor, as you have rightly mentioned, the leadership plays a key role in molding the clinical pharmacist to talk to a level of the clinician. So that's more important. That's what we expect from the clinical pharmacist in the next 5 years. Grow up yourself professionally, grow up yourself to be a competent person, and get the right information. If you have just telling one wrong information, entire consult or entire belief in you will go off. It will also put up a problem to the person who is sitting somewhere and giving the orders also. So that's very, very, very important. So that confidence and professional integrity is very, very important. So that's what we expect from CPs.
True.
Being an angel to us, like when we walk as an infection control officer, we all come this side and this side like an angel supporting us. It's easy now, actually. So I can fight. If one CP drops, I can fight for another post, right? If I feel like what is the use? There is no use. Then I won't fight for it.
True. Definitely, the presence need to be fulfilled, and also it need to be justified.
Yeah.
Exactly. Yeah, it's so good listening all these insights from you, ma'am. I hope all these experiences made us your experience, sharing your experiences with us, made us to understand new origins of this, taking it to next step. So definitely we will consider all this. I hope our audience also will be getting benefited because of this. And we are looking forward to consider all this and take it to next step. We'll try to implement this in upcoming days and take it to the another level. So I hope this session is so interactive and it's nice meeting you again. So this is an end of session. Thank you so much all for listening us very patiently. And have a good day. Bye bye. Good night.
Thank you. Thank you, everyone. And thank you, FCPA. And thank you, Satya. Good night, everyone.
Yeah. Good night, ma'am.